Okay, welcome to today's meeting of the Health and Social Care Select Committee at the London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by health partners in adult social care and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm chairman of this committee. Before we start, I have some important housekeeping for everyone present. Please ensure that any mobile phones are on silent. We're not expecting a fire drill, so if a fire alarm does go off, please follow Nikki out of the building. Please keep your microphones muted when you aren't speaking and then unmute to speak. As chairman, I will call on those to speak during the meeting. Fantastic. Right. Nikki, do we have any apologies for absence?
Chairman, we've had apologies from Councillor Punja and Councillor Sansapuri is here as her substitute.
Welcome, Robin. Do we have any declarations of interest? No? Fantastic. The minutes of the last meeting, which congratulations, Nikki, for doing those. That was a very long, detailed and interesting meeting. So, sorry? One change. Oh, yes. Can you remind me of
Chairman, just an update on the minutes. I am aware that there was a slight error at one point. There may be more if members have got any comments, where I said that there was 42 GPs in the borough. It's obviously 42 GP practices, not 42 GPs. So I will update that.
Thank you, Nikki. Philip.
Just to echo your sentiment and suggest we place on record our thanks to Nikki for capturing such a lengthy, in-depth discussion so succinctly. A great piece of work. Thank you.
Very happy to do that. Okay, June, thank you for seconding that. Excellent. So we can move on to our next agenda item. Oh yes, well, press or public, everything we're talking about today is in public. That's correct. Fantastic. And so we move on to item 5, which is the Hillingdon Safeguard Partnership Annual Report. And we have Bucky, is it Junaid? Junaid, yep. Assistant Director, Access to Support Services at London Borough of Hillingdon. Susie Gladish, Quality and Implementation Manager, Safeguarding Partnership, LBH. And we have Sandra Taylor, who is in charge of all of us and everything. In this room anyway. Who would like to kick it all off?
Okay. So the report that has been provided covers the work of Hillingdon Safeguarding Partnership in the financial year of 22 to 23. The vision of our Safeguarding Adults Board is for Hillingdon citizens, irrespective of age, race, gender, culture, religion, disability or sexual orientation, to be able to live with their rights protected, in safety, free from abuse and free from the fear of abuse. So the summary that I'll give you today will focus on the safeguarding adults side of the work, because that's the purpose of the committee this evening. For people that aren't familiar with Hillingdon Safeguarding Partnership, essentially what we have is mirrored arrangements across children's and adults, whereby the 3 statutory partners, the local authority, the Metropolitan Police Service and NHS North West London, ICB, have shared an equal responsibility for safeguarding in the borough. We have 2 senior strategic boards, the Safeguarding Adult Board and the Safeguarding Children's Partnership, both of whom report to a shared executive leadership group made up of the statutory partners. The reason that we have the arrangement set out that way is because it allows us to really focus on the concept of think family, so that we understand that children exist in families with parents, and parents and adults often exist in families with children. So, as I said, the report sets out how the partnership has worked towards achieving the vision of the Safeguarding Adult Board and the Safeguarding Children's Partnership. Where relevant, a summary of both areas of work is provided, because this highlights the principle really of Think Family, and ensuring that the voices of our adults and children with lived experience are heard and are promoted. So in the last year, our independent scrutineer, Alan Caton, came in and focused on the impact of our strategic work in practice. He looked specifically for adults at the functioning of the adult MASH, and this provided It provides a kind of a helpful external view on practice.
Could you just explain what MASH is?
Oh, yeah, of course. It's the Multi-Agency Safeguarding Hub. So it's a team made up of the local authority as the lead agency with various other partners, police, health, hospital, different agencies coming together to share information about adults so that a decision can be made about whether or not the criteria for adult safeguarding is met, or whether there's a need for support that can be best met via a different route. Yeah. Yep. Fine. Okay. So Alan Caton focused on the adult MASH, and his findings are published in a letter on the Safeguarding Adult Board website in full. But in summary, what he found was a strong partnership. He found that we are open to scrutiny, that there's challenge within the partnership, and that challenge really reinforces our ability to continuously strive to improve practice. He didn't find any areas of poor practice in our adult MASH or in our adolescent safeguarding services, and he highlighted strong leadership from the executive leadership group with this clear sense of joint and equal responsibility. He commented around the partnership is one that's built on high support, high challenge, and where difficult conversations are encouraged. One of the key pieces of work that we completed last year was a piece of co-produced quality assurance, exploring practice, the voice of the person. So the Safeguarding Partnership team, we worked with children and adults with lived experience to develop a questionnaire or a set of questions that we then used to engage with other children and other adults who were receiving safeguarding services in Hillingdon. We used an approach of semi-structured interviews to do that. Some of the outcomes of that so far, it's very much a work in progress, but we had children presenting to the Safeguarding Children's Partnership the findings, and adults presenting to the Safeguarding Adult Board the findings of the Children and Young People's Annual Report that's come as an outcome of that too. Positively, most children and adults felt that they were listened to by the professionals that they were working with, and that's professionals across the partnership, so not specifically social care. And they also gave us some really useful insights to inform how we make sure that continues to happen, and how we make improvements where there's opportunity to do so. So the work of the Safeguarding Adult Board is undertaken by a network of subgroups. Each subgroup is working to progress a specific area of practice or specific topic area. So in that year, we had subgroups working around self-neglect, around domestic abuse, and the conclusion of our Making Safeguarding Personal subgroup. Each of our subgroups across both adults and children operate using the same really basic framework of prevention, identification and response. And the idea behind that is that it becomes familiar to all of the different agencies that are involved in safeguarding, and it just gives a really helpful structure really to think about solutions and to think about areas where we can make improvements, and then to make said improvements. So some of the things that have happened within the subgroups, and I'll not go into them all in detail because I'm sure we will be here for 3 hours, but our domestic abuse subgroup focused on a domestic homicide review that had been completed previously, and looked really carefully about how we can disseminate the learning from that. We also looked at practice around domestic abuse across all different agencies, and making sure that we've got appropriate training in place. Those sorts of things happened. Within our MSP, so Making Safeguarding Personal subgroup, that subgroup completed their action plan, and they undertook a multi-agency audit, disseminating the findings from that through a webinar, developing practice briefings which are all published and widely circulated across the partnership. And then our self-neglect subgroup did some work around self-neglect and hoarding, and looked at particularly the intersection with the Community Safety or Safer Hillingdon partnership, so the community safety side of work. One of the other things that we've done a lot in the last year is around awareness raising activity. So again, we're thinking there about, prevention. So we've driven awareness-raising activity around suicide prevention, around Safeguarding Adults Week, mental health awareness, Safer Internet Day, which is often more associated with children. But actually, if you think about some of the care and support needs that can develop for adults, actually there's lots of relevance there for adults there too. And then coming up, we're looking at wearing red to show racism the red card, which is in the next 2 weeks. So that's a kind of an ongoing programme of awareness-raising activity. In terms of learning from practice, we have learning from practice framework for children and for adults that sets out really how we learn where there has been a serious incident, and also how we learn where perhaps the criteria for a serious incident isn't met, but there's still something that we need to understand, and maybe some useful things that we can identify and explore within a specific case. So we published a thematic SAR around self-neglect, and we held a safeguarding learning event to disseminate the learning from that. The themes there were around the importance of practitioners understanding lived experience, so what is it like to be this adult in this particular situation, the challenges that there are in identifying and responding to coercive and controlling behaviour, where perhaps it's not in a I think we often associate domestic abuse and coercive and controlling behaviour with kind of intimate partner relationships, but we know that it can affect any relationship within a family, so thinking about that. A term called diagnostic overshadowing, is that something people are familiar with? So that's about if, for example, I'm meeting someone with a mental health need, a known mental health need, I also need to be thinking about their physical health. I also need to be thinking, actually, is what I see in front of me, is that stemming from the mental illness that I know about, or is there something else going on that we need to understand? So thinking beyond the immediate presentation. And also the application of the Mental Capacity Act, so legal literacy for practitioners. In terms of quality assurance, we implemented a quite large multi-agency quality assurance framework last year. Some of the activity that was included within that was the Voice of the Person review that I've already spoken about. We also looked at the functioning of community MARAC within the self-neglect subgroup, and we looked at there's an audit called the Safeguarding Adults Partnership Audit Tool, which is snappy, known as the SAPAT, which we started, but actually found that the tool itself wasn't quite fit for purpose. And that's something that's developed on a pan-London basis. So we fed that back, and we're hoping to have a more user-friendly tool this year. If not, then we'll develop our own and do it that way. In terms of training, we have a very broad training offer, again covering children and adults. We have developed some formal and informal partnerships with sector leaders, particularly around child sexual abuse and FGM. And if we're thinking about FGM, so female genital mutilation, again, that's often seen as a child safeguarding issue, but what we know is that it has a significant impact on adults as well. So we're trying to kind of build those bridges across the two sort of strands of safeguarding work. We've introduced a webinar program that's been very well received. That basically is between a 90-minute and 2-hour long, sharp, focused session that people can access more easily, really. And those are then made available online for people to access, or practitioners to access at a time that suits them. And we've also introduced a late cancellation policy because what we were keen to do was to improve engagement with training, and we're just doing some work to measure the impact of that now. We have developed a wide range of practice briefings that again are published on the website, widely circulated across the partnership, and actually have been picked up, some of them regionally and nationally, by other areas, perhaps looking for something that we've done some work on. And we've also introduced our newsletter. So the newsletter is published every 6 weeks or so, depending on need, and just provides a kind of a helpful overview for practitioners across the partnership about what they need to know. So that could include things like changes in legislation. It could include what good practice looks like in respect of neglect, or it could be anything. So the newsletter pulls it all together and is sent out. In terms of our highlights from partners or headlines from our partners, the local authority have seen a sustained increase in need in terms of the referral rates for adults. So we saw a 13% increase on the previous year. But some of the systems that were put in place within the adult MASH have reduced the need for services to escalate to adult safeguarding inquiries, because they've been able to put safety plans in place early. And similarly, there's been some development within adult social care around systems and processes that have provided some insurance around Care Act compliance as well. You'll see within the report that neglect was the most common type of abuse during the financial year. Our colleagues in the police have seen a sustained increase in domestic abuse with the West area, so that's not only Hillingdon, but this part of London, having the highest reports of domestic abuse across the Met. And that could be due to improved reporting, or it could be indicative of something else. But it's useful to know. Similarly, our CATE team, so that's the Child Abuse Investigation team, is also one of the busiest in London. So there's lots of pressures on partners. It's been a very busy year. Our integrated care partnership have been driving the use of health checks for adults with learning disabilities, providing training and support directly to primary care. They have built on an existing network of safeguarding forums for GPs and added in safeguarding forums for practice managers, so that we've got kind of multiple routes into surgeries, which is again very helpful. And our colleagues within Central and North West London NHS Foundation Trust, so the community health services, have reviewed all of their referral forms to include a specific question around consideration of mental capacity, and they have a dedicated nurse in place, a nurse specialist who advises and supports practitioners. They've held their annual domestic abuse conference and raised awareness about themes of intersectionality, and also they have a network of domestic abuse ambassadors through the system. Hillingdon Hospital have been focusing on training. They're looking at the mandatory or making mandatory the need for adult safeguarding training at the moment, and they have also seen an increase in demand around mental health and safeguarding, which I think reflects some of the challenges that there have been across the community post-COVID and with the cost of living crisis. And they continue to see a really positive impact from the co-location of the IDVA, so the Independent Domestic Violence Advocate. They have one based in the hospital who's on site and able to offer advice and guidance. And they've been focusing on ensuring safe discharge and on safeguarding practice in relation to pressure ulcers as well. So our priorities for the coming year for adults are neglect, and our Safeguarding Adult Review Panel, so looking at how we embed and build on the learning that we've already identified. And we've got this ongoing focus that's threaded through everything around the kind of voice of the person and making sure that we learn from practice. So I appreciate that's quite a lot. It is quite a lot report, but I'm happy to take any questions.
No, thank you. No, it is a lot. It's a good report, and also there is a easier summary at the end of the report for those who don't want to read the full report, which is very good to see being produced. I've got a couple of questions around the same sort of subject, and I'll open it up to other committee members. But it's just in terms of reporting. So how do people know who to report to, and what sort of feedback do they get? Because obviously safeguarding is one of these issues that you have. It's very, very important. You put the name on it, safeguard, but people who are going through abuse or witnessing abuse, reporting is not necessarily an easy thing for them to do, and sometimes if they do report, waiting then afterwards is not necessarily an easy thing to do as well. So just a little bit about, how do people know where to report to, and also if somebody does report, what sort of knowledge and support might they get? I know it's a very broad question because it obviously depends completely on the situation.
So I can speak to how we raise awareness of how to report. One of the things that we mark every year is Safeguarding Adults Week. And what we do with that, we've produced a range of different posters covering all different types of abuse and neglect that an adult might experience. These are shared across the professional network, so I know go and visit the hospital or go and visit a community health provider, you'll sometimes see one of our posters up to say actually domestic abuse can be an adult safeguarding concern. This is how you report. You can do so either online or by phone, or you can contact the domestic abuse HDAS, so Hillingdon Domestic Abuse and Advice Service. So that's how we would raise awareness of that, kind of by using our network of contacts across Hillingdon, across the borough with all different services. In terms of how people would know what to expect when they report a concern, I might just hand over to my colleague for that.
Thank you. So in terms of safeguarding the reporting as well, because we all know according to the Care Act that it's everybody's business, so a lot of times we do get a lot of phone calls even from members of the public. And from there we would screen and triage it from safeguarding point of view, because it will come directly into our box, adult social care safeguarding box. By screening and triaging it depends on, as you know, the nature of the concern that's been raised. So the first point of call for us will be to put up preventative measures in place, which is in essence making sure that individual is safe, because their safety is paramount to us. Sometimes that may mean that an officer would have to go out to carry out a welfare check to find out how the person is getting on, and from there on we'll make a decision on whether he requires further inquiries, he going to other service area for further inquiries, which is the section 42.
I think it's a really good point that you raised, and something that we were actually talking about in our leadership meeting this morning around, so the partnership absolutely put posters up, share information, and partners. So if you go into a medical centre, for example, you might see one of the posters, etc. Some of you who have been here as long as I have might remember that we had a huge campaign a few years ago where you would see them on the bus stops and on buses, and I think that we probably need a bit of reinvigoration around how the public, so not people that are seeking to look out on how to find it, because our website is there and people can find that, but actually to prompt people's thoughts about the need to report matters if they're concerned about something. Having said that, our reporting figures are excellent. So we do have a really good high level of reporting by a whole range of people, as Bookie says, from family members to concerned members of the public to professionals. So we do have a good level of reporting, but I guess what I'm saying is I think it's time for a reinvigoration of safeguarding indeed is everybody's business, and we want everybody to know how to report that. So it's a good point, and I'll take that away.
Thank you. And my second question sort of related to that is, you mentioned the mash, which I like because I like mashed potato, but it's a different type of mash. But ultimately, one of the potential issues with such a thing is obviously information, stories, incidents getting lost in the system. Now, the ideal is obviously the mash means that cannot happen or should not happen. But how do we make sure that actually if something gets reported, maybe it gets reported to somebody who doesn't deal with something directly, because obviously people will report when they want to, when they have an opportunity, and so then they'll go into the system, maybe go to somebody else who would be somebody else's responsibility to deal with. How do we make sure in that sort of way that the information and the need isn't lost?
So when somebody contacts us, their contact comes through our contact centre and is immediately picked up and looked at by the team. So an entry is made onto the client system. So that information that's passed to us is then screened and reviewed. So we get that information and somebody will assess the need to be able to take action in the short, medium or longer term. And by longer term, I'm talking about probably 48 hours. Immediate would be obviously straight away at that point in time or sometime, and the medium term kind of sometime that day. So people going through MASH as a safeguarding matter is a real safety net in terms of any approaches to social care for support, because we pick them up at that point in time. We maintain that record, so if there's no further action, so somebody says, oh, I'm a bit concerned about, we'll have that on record. Should a further inquiry come in, then we can refer back to that record to be able to have something to form the basis of an inquiry, that if there are concerns about somebody. It's very helpful in terms of people, particularly we've talked a lot today about neglect and self-neglect, where other people are generally concerned about those individuals and want to be raising those points. So it is helpful to have that kind of track record.
Are we confident when a matter is dealt with that it's closed, shall we say, or if it goes into a more longer term issue, that it goes into the system more in the long term issue? Because the question I'm really sort of trying to get at, and that was a very good explanation of what happens, is does it get dealt with? Obviously the fact stuff's recorded, and if somebody, I assume, has, it comes up on the system a few times, then that can be picked up in that way, which is absolutely great. But are we confident that the issue will be closed or in a place where it's being dealt with in a long-term manner?
So I'll answer a bit of this, but Vicky is certainly our professional in the whole system of safeguarding. So yes, we're confident that it will be dealt with. Timescales are difficult to actually say, so we would try to address matters as quickly as we can. In the first instance, we're always going to deal with a priority and a safety matter, so a safety plan in place to make sure anybody is safe from whatever it is that the potential harm. Following that, it depends on how soon it can be closed, and so therefore dealt with, will depend on the nature of the inquiry and the investigation. So if it proceeds and it's actually connected to a police investigation, you'll see from the report that can be a very, very lengthy process, and that's not something that we're empowered to change. We work closely with our police partners. If we've got concerns, we can raise things with the police, etc. But we have to allow those criminal processes to take place, and then we can close matters. I think I'll let Vicky follow up, but for me it's about keeping families very well informed, people involved very well informed, and closing things when the time is right to do so. Sometimes that's much earlier in the process if we can't influence the outcome, and sometimes it's much longer. So as long as we keep people up to speed, I think that's the priority for us. Is there anything else?
No, I think that's fine.
Philip, you had your hand up.
I did. A very good report, thank you. I mean, safeguarding is one of those things that we work our socks off at, and at the end of the day we still can never be comfortable. There's never room for an ounce of complacency, and it's something we all worry about, officers and members alike. But a very good report. Good to see that the independent chairman is highlighting no evidence of any poor practice. But I do have a couple of questions from reading on the report today. The headlines reiterate what we already know, that there's equal responsibility between the local authority, the police and the health partners. It doesn't always feel like that though, does it? I certainly did it in my time in Cabinet, and certainly looking at the report there's evidence that some of the meeting chairing, some of the involvement in meetings is tending to fall back a bit to the local authority. And I'm wondering if perhaps there's a wider issue there in terms of the strength of that partnership, and whether there are any gaps which we need to address to strengthen our approach moving forward, recognising the pressure that all public bodies are under, of course. So I suppose that's my first question. Do you want to answer that one first?
Yeah, do them one at a time.
Okay,
That's
fine.
easier to answer,
Yeah.
So in terms of the chairing arrangements for the subgroups, you're absolutely right. There has been a shift in kind of quite a broad ownership of that across the partnership to more local authority focused. But what I will say in terms of attendance at the subgroups, they are still generally very well attended. So it may be that we have someone that is perhaps new in post, particularly for colleagues within the police. You know that quite often people will have changes in role within the police, so we'll have a new officer in. They may not feel comfortable or confident in chairing a meeting, but that doesn't mean that they can't make a meaningful contribution in terms of their professional expertise when they attend. And that is something that we are working on and are aware of. So the Safeguarding Partnership team, my team, it's a very small team, but we are in many ways independent actually of our colleagues within the local authority, although technically employed by the local authority, so it's a slightly strange situation. So we do have members of my team chairing subgroups so that you retain that element of kind of independence and oversight and kind of drive. Where we have had issues with non-attendance at subgroups from particular agencies, there is a process of escalation that is followed. So we'll contact the individual professional, irrespective of agency, and try to find out perhaps what the barrier might be. It may be that they've had a change in responsibilities and can no longer manage the time. It may be that they've had a change in role. If we're unable to work with a professional or a strategic lead to kind of pull them back in again, then that would be escalated via the board and to the chair and ultimately to the executive leadership group to address. So that's kind of where we're at now.
Okay, thank you. I mean, just in answering asking my second question, I'll throw in a cheeky supplementary around that. There is, I noticed, for example, that the domestic abuse group isn't meeting according to the report. I wonder if that's by default or design. Perhaps I can cheekily ask that question before I do my second one, if that's right. That struck me, that was all.
Yeah. So each, if you imagine the breadth of topics or issues that can occur within safeguarding, domestic abuse is one of many. So each subgroup at the beginning sets out and agrees at a terms of reference, sets out actually this is what we're hoping to achieve, this is what we want to do, this is how we're going to do it, and this is how we'll know when it's done. The domestic abuse subgroup concluded at the point of the conclusion of the action plan. So the action plan was completed, but that doesn't mean that we no longer pay attention to domestic abuse. So one of the subgroups that we have that I didn't mention, so probably not helpful, sorry, is our Practice Development Forum. And that is a subgroup that covers both adults and children. And it pulls together all of the findings, all of the work that happens in all the different subgroups, and also some of the work that perhaps doesn't have a designated subgroup, and make sure that we continue to progress it. So domestic abuse remains very much on the agenda, and I attend the Domestic Abuse Steering Executive, and as a safeguarding partnership we continue to support colleagues in community safety, we continue to provide training. We just don't have a designated specialist subgroup working on that particular topic because the action plan was completed.
Thank you. It's good to know there's nothing untoward about that. It's just something I noticed. So my second question then, just coming to this, is I suppose the question of harder to reach communities, because one suspects that if there are going to be safeguarding issues, that there may perhaps be disproportionately more among our harder to reach communities. There may not be any basis for that, but one might think it. So if there were any basis for it, could I ask how we are reaching out to harder to reach communities with some of our messaging around awareness for safeguarding and abuse issues, please? Thank you.
So when we think about those individuals, families, communities that are harder to engage, that puts the onus back on the professional network to reach out and to work with them to make sure that we do have that increased awareness around safeguarding issues. what we've done, I'll give you an example of something that we've done in the children's world, is engage directly with faith leaders, with community groups, with the voluntary sector around issues of contextual safeguarding of serious youth violence. So we have provided webinars, training, tools, resources, and we also reach out. So everything that we do is shared with colleagues within the Stronger Communities part of the council, who have all of those kind of links into all the various different voluntary sector organisations that are, generally speaking, quite well embedded with communities that are harder to engage. So that's how we try to do it. In terms of how effective it is, I think that's probably difficult to measure, but it remains something at the top of our list, if that makes sense. Okay.
Thank you. June.
Always have to be reminded. Thank you very much, Susie. Very good reports done. I like the bit of the voice of the child. My question is, in the strategic high risk panel here, it was recognized that children who are from a global minority ethnic group are more likely to be treated as older as they are. So that has got some impact in regards to how what sort of safeguarding is in place for them when they come forward, because sometimes sexual abuse happens with kids who would not come out and report it, but at the same time it's being looked at in a different form. So can you tell me, how does the hub help that, and how does the child voice get heard if it comes forward, and what is in place to help and assist that child, especially in a family setting where family dynamics are different, because different cultures have different ways of how they deal with children?
So that is led by colleagues within children's services, and what we're talking about with the concept of adultification is that children who are black or Asian or from other global majority ethnic group are often seen by professionals, by the community, as being somehow older than their chronological age, therefore less vulnerable, less in need of protection, and more accountable for their actions. So if you think about some of the issues that we see in terms of disproportionality within youth justice, within school exclusions, although not in Hillingdon actually, but on a national level, we often see that our black children are held to be more accountable for their actions than our white children. So in terms of what we do about that, we have, as a safeguarding partnership, we've provided training around adultification by a sector leader called Listen Up, that is the charity that coined the term adultification and has led lots of research around that. So that's been delivered across the partnership. You will see within the work that we produce and our practice guidance and our practice briefings, we are continuously talking about language. So thinking about how we talk about children, making sure that we're not referring to youths or any other term that could in some way disguise the fact that we're actually talking about a child in need of support and protection. We work with our schools and with our community health and acute health to make sure that we're all kind of in agreement really around the need for children to be protected irrespective of their, because they're a child and a child first and foremost. So I'm not sure that I'm able to answer your question more than that. I mean, there are various, there's a vulnerability risk assessment that's completed within children's services for any child that comes to attention where there are concerns about some form of exploitation, whether criminal or sexual. That takes into account the impact of various aspects of that child's identity. And so from an operational perspective, it's kind of addressed on an individual basis with children. We then have I realise this is the adult select committee, and I'm going off on a tangent around children, but I want to answer your question. So then there is an operational high risk panel that will pull together themes and issues. So if, for example, I'm just making this up, so say we've got a developing issue in a part of the borough, that can be picked up and identified and support put in place around that area of the borough. And then we have the strategic high-risk panel that also works at a kind of very senior level across all the different organisations involved to unstick any blocks and to kind of drive that strategic response to exploitation. And within that, we're including issues of adultification and anti-racist practices, and it's kind of threaded through everything that we do. We're about to next week, in fact, we're doing a lot of work around raising awareness of anti-racist practice. So I think you probably see some of us have our Show Racism the red card badges on. There are various posters up across the borough, practice briefings being produced that's gone out that highlights the need to be anti-racist in all forms of practice. So I don't know if that answers your question particularly, but I think it might
some of it, because you said you're not covering children, and children is part of this report here as well. So
absolutely.
This is why I pose a question to you on that, because it covers all aspects, not just adult, but straight across the spectrum.
Thank you. Do you have a second question?
Yes. My other question is the core membership and the partnership with adults in the adults group and hubs. How does with the adult hub across the board? How does our local residents access that to enable them and to access the hubs, and what is it made up of? Who are they made up of?
Yeah.
So the adults, I guess it's the adult MASH we're talking about, the multi-agency. So it's made up of social workers, and we do hold a daily high-risk meeting which all professionals attend, which gives them the opportunity to discuss any challenging cases they might be faced with. So when I say multi-agency, I mean housing, children's, the police, they do attend as well. Well, I can't remember, but CNW Health, the THH, so it's the hospital, health professionals, ICB, in order for them to kind of discuss some of the challenging cases. So it's a daily thing.
So when safeguarding issues arises within a family or within an individual in either in their homes or wherever they are, and if they're not in the radar under the health system, under the mental health system, how do you what effect does that have, and how can that individual or individuals able to know and access the system?
So I think just like Sandra mentioned earlier on, the contact, all referrals will come via the contact center, and from there it will come directly to the safeguarding, the MASH team, the adult safeguarding email box. From there we will screen, and part of that screening is to actually identify the needs of each individual. So even if it's a family component, we will make a referral to the children's services if there's a child, and vice versa. If there was an adult in the household, then they will make a referral directly to us, and we will go through our checklist, which is a risk matrix, to just kind of identify what the risks are and put a protection plan in place from that way on.
Pardon, sorry. So I think mainly we cover the adult because the children and families committee will cover the children part of this report. We get the full report because it's interesting and an effort to split up. So generally it would be the other committee that cover the children stuff. Do you have a burning question about the children aspect that you want to put out there? Okay, fantastic.
One more.
Okay, great.
So one more question. The Mental Health and Safeguarding Group is set form in 2021, and it is fulfilled its stated purpose. Can you explain to me what fulfillment and what is that stated purpose?
So in terms of mental health, if anyone was to come through our door, i.e. a referral, the first point of call for us is to check if there are any, if they're previously known to us. So if they're known to mental health service, what we tend to do is notify the allocated social worker because they will know about it. But it doesn't stop us from actually taking them through our own route, which is screening and triaging and putting a protection measure in place for that individual before we then signpost them back to the mental health team. However, if they're not known to them, we can still request for an assessment of needs for that individual, depending on what the presenting needs are, for them to carry out an assessment, and the outcome of that will be fed back to us and a decision will be made.
Thank you. Sorry.
Just building on that, so from a strategic perspective, the mental health subgroup, mental health and safeguarding subgroup, the stated purpose was to identify and share local and national learning from serious cases, to build on expert practice knowledge from subgroup members, and to embed that in systems and practices across the partnership. So they were seeking, as a strategic multi-agency group, to reduce the risk of abuse and neglect and self-neglect for adults with mental health problems. So what the subgroup achieved was to develop links with the existing kind of health-led strategic forums. So one of the things that we often find is that we have, so the safeguarding partnership, we might be looking at mental health from a safeguarding perspective, but obviously we've then got mental health transformation boards, various other senior strategic groups that are looking and working towards a particular outcome. So what we try to do is to make sure that we are all kind of pulling in the same direction, that we have shared priorities and that we work together. It means that it's more likely to be effective and it reduces duplication, which is a good thing, so it's less likely to be confused. Some of the things that happened within the subgroup, we developed and delivered a multi-agency webinar focusing specifically on safeguarding adults with mental health concerns. So going back a little bit to the issues of diagnostic overshadowing, thinking about physical health needs for people with mental health issues. The webinar continues to be available. The practice briefings continue to be available. We continue to raise awareness of mental health issues, so marking World Mental Health Day today, recently doing a lot of work around World Suicide Prevention Day. So it continues to be part of our ongoing work, albeit the dedicated subgroup has concluded. There was some scrutiny of local quality assurance processes, so we're thinking about how do colleagues within CNWL, within the mental health teams, how do they monitor and scrutinise their practice within their organisation, what happens within adult social care, what happens within police, so just kind of pulling all of that together and seeking assurance about how that is functioning. And one of the other things that happened within it, so the local authority introduced a focused quality assurance programme within AMP as a kind of a direct result of the work and the discussions that happened within the subgroup. So there's a range of different things that have happened, but that's just some highlights for you to show you. Okay.
I've got Tony and Rita both want to ask questions. If they don't cover your question, then you're welcome to come back in the end. Tony.
Thank you, Nick. Thank you for the report. I think it's very encouraging in some words, but and the easy read one was really good. It feels to me.
We should ask that all the time.
Yeah, I know we should do. Philip pinched my first question, but just on the adult MASH, there's been significant improvement, I notice, on the number of Section 42 inquiries and the time it's taken to come to an outcome. Is there any specific reason for that at all? I've got another question.
The reason being is because of the protection plan we put in place. So there's been a lot of preventative work. So previously, when safeguarding concerns are raised, it's actually referred to other service areas, but because of the high demands of other staff professionals are getting on with, so we've taken that initiative from MASH point of view. So when it comes through to us, we make sure that there's a protection plan in place. And one of the things we've found is that most of the time it doesn't then require further inquiries. We're actually able to mitigate risk at the initial stage. Hence, we're able to close it from that end, ensuring the person is safe and signposting them in some cases. So that's actually made a positive impact in terms of the referral rate because it continues to be on the high.
Thank you very much. Anyway, it's encouraging, and let's hope it continues in that trend. Just my other question is about the 13% increase that we've had for the local authority referrals. You may not be able to answer, but the budget, how do you manage the budget on this? Is it...
Sorry, that's a conversation I had with Sandra this morning.
I think the key point though is how we provide the service we need to provide to those who need help. So that's how do we help those people who need help? Essentially.
I think Bookie's given a good example of the fact that they're able to turn down the number of the days it's taken to close cases by a restructure of how we manage the safeguarding concerns, and often the restructure is seen as a bit of a negative approach when you're talking about heavy demand, budgets, etc. But actually, this is a very positive piece of work in terms of the difference it's made in allowing people to come straight in, have an emergency plan put in place. It gives you space and time, or the professional space and time, to be able to say, actually, we don't need to pass it through to the longer term teams who do the work and the inquiries, because we can see here what we've done is enough, we've given enough information and support to this individual, and we can close this case. Whereas previously, we would actually take it in through the contact centre, and it goes to the teams, the social work teams, who are indeed inundated, because you can see by the sheer demand that's problematic. And so they're going to get to the most significant first. So you get that delay automatically built in. So in answer to your question, the way in which we manage demand is by that triaging process immediately at the front door, immediate action with a team of people. So we have one team of MASH, meetings every day at 12 o'clock, prioritise and make sure things are dealt with straight away. And that enables the closure of cases so much quicker, and it enables us to manage the demand. Where we have an awful lot of demand coming in is we get reports from the police every day about incidents across the borough, and so we're working very closely at the moment with community safety team and the safer neighbourhoods, etc., and working with the police to try and work out how we because every one of those comes in as a contact, we have to look at it, scrutinise it, and make sure that there is no work for us to do, in effect, in relation to that contact from whatever's happened tonight will come in tomorrow morning, for example. So it's a process of trying to deal with things immediately that has helped us manage the demand coming through the front door. If the demand continued at the rate that it has over the last year, it's currently manageable, but should it continue to increase, we'd have to do two things. We'd have to consider strengthening the team, but we'd also have to ask the police why we're getting this level of demand, what it is our partners can do to help us try and stem that flow to a lot of the stuff that Susie's talked about today about early intervention, good education, supporting people, giving people the right information before they tip up for actual safeguarding support will be the next course of action.
Okay, so you're actually doing, you're making the budget stretch to, you're doing more with your limited resources, but you're chopping off some of the stuff at the edges, I'll get your answer.
We've developed an efficiency in the practice, so it's a safer, quicker, more responsive service by taking teams out of main teams and setting a separate MASH team, so multi-agency team. The decisions are made multi-agency, and it means that when a decision is made, it's made that day, and those meetings are happening every day. So intensive support, early intervention is helping to manage the demand.
Yeah, I heard better systems rather than cutting corners, but
definitely.
It was definitely a very good question. Also, your point about if this carries on continuing, then something to look back at. Cool. Rita.
Thank you, Chair. Thank you very much, ladies, for the report. My question is around the training programme. It's pleasing to see that 96 and 98% of the delegates have given very positive feedback. My question is around, and we all know that training always awakens any dormant processes and thoughts that have lain dormant. So how do you then monitor or reach out to professionals that don't attend any training sessions or are less adverse to training sessions?
That's a really good question. I think that is owned by the safeguarding leads within various agencies. So what agencies will often have in place is a mandatory training programme that says these are the courses that you need to complete this year, and you need to complete them at X frequency. So that's managed and monitored, particularly within health services, very closely. In terms of reaching out to agencies, the way that we I'm going to use the word advertise, that's probably not the right word, but the way that we kind of draw attention to our training offer is via the strategic leads, because what we want is for leads within agencies to be driving that within their own services, because for example, I had a conversation with one of the safeguarding team at the hospital about this very thing yesterday. Actually, a nurse or a doctor in A&E is probably not going to listen to me saying, we think you need to do this training, with quite the level of attention that they would listen to a senior leader within the hospital saying, we need you to do this training because it matters, because. So it's that, really. It's about engaging with the leads. Yeah. And obviously, for colleagues working within safeguarding, there'll be supervision that's used to monitor training, to identify needs for training. One of the other things that we do, and I think it probably doesn't quite answer your question, but is relevant, so where we are seeing particular issues coming up in learning reviews or in statutory reviews, whether locally or nationally, we'll look at our training offer and say, actually, do we have something that works to disseminate this new piece of information? Do we need to pay more attention to Mental Capacity Act? Do we need to pay more attention to safeguarding adults with mental health issues, for example? And then we will develop our own webinar that is more easily accessed by people. So there's a range of different methods that kind of vary according to kind of direct operational management of frontline practitioners, strategic leadership within agencies, and then the partnership together as a whole.
Thank you. At least it's being monitored in some shape or form.
Sorry, and just to add to that, it's part of the CPD for staff as well, so it's their continuous, progression development. Just to add to what was said. Thank you.
Ginger, would you like to ask your last question?
Actually, it's more than one, but I'll just ask this one. I'm concerned about the self-neglect group and the audits. I'll link two in one, but hopefully you'll be able to answer them. The self-neglect and the hoarding behaviour, within the audit, it says here in the audit, it's considered barrier to best practice. How is that managed by you guys in regards to that? Because hoarding is quite a big problem developing within the community now, and self-neglect, and that's from COVID, people with mental health issues, it's been affecting people's functional needs. But in the borough. Can you tell me how you manage with that and what came out of that audit?
So previously, I'll say prior to COVID, we, in terms of hoarding, we've got a part of our risk assessment where we would consider people's needs around the care and support needs. So if someone was coming through our door and they do not have a care and support needs, we'll automatically close that down. But since COVID, regardless, if anyone had care or whether they have care or support needs or not, we will still follow that through. So one of the things that came out of the self-neglect subgroup was professionals obviously coming together. So we're now working very closely with housing because, you know, they'll go out and do their inspection. There was a lot of gap during COVID as a result of that. A lot of the cases now they bring to the 12 o'clock high-risk meeting every day, so if they had concerns. And recently, I think it was last week, we just devised a new pathway again for the housing just to support this issue around hoarding. So I'll say previously, maybe we're not doing so great, but I think we're getting better by the day by working with professionals, liaising with them. So if there was any concerns, they know there's a forum where they can present it to, where we have partners who will be able to contribute to the support of that individual.
Thank you.
And the audit, you really understand the audit? What came out of that audit?
No, go on.
So the findings of the audit were shared with the Safeguarding Adult Board, so that's with the strategic leads that are involved across the partnership from all different organisations. We did some focused work raising awareness around referral pathways. So actually I'm a frontline professional. I identify hoarding concern. What do I then do? So we did some work around that, using practice briefings, using the newsletters, using our training. We commissioned specific training around self-neglect and hoarding. So that's in place and is being generally quite well attended, again, by a range of professionals across the network, so from different organisations. We did some focus work around there's an assessment tool called the clutter image rating scale. So you have photographs where so we have this shared language across the partnership. So if a nurse goes out to do a visit and is worried about the condition of a home, she can look at the clutter image scale and say, actually, this is clutter image scale 4. She can write that down on the referral, comes through to adult social care. Adult social care can look at it and have a really good understanding of what that means. So this kind of shared language and shared ownership, of responding to hoarding, and we've also kind of threaded into other areas of practice. So I mentioned earlier the work around Mental Capacity Act and understanding how to assess, when to dispense with assessment because there's a safeguarding concern, and then what to do. So it's threaded through quite a few different areas of work, but that's the kind of the focus stuff that happened in consequence of the audit. Okay.
Right, thank you very much. You've been here with us for an hour, and I think that signifies the importance, obviously, of this report and what it covers. Thank you so much for providing a good report, and can you send back your appreciation to those who do this work, because it's so important to getting a lot of other things right. So thank you very much, and we look forward to seeing you again next year. Thank you. Excellent. Okay, right, so our next agenda item is item 6, which is a further update on the GP pressures review that was done for a previous select committee. It went to Cabinet in January 2020. Nikki, so can you sort of explain how we're dealing with this one?
No problem. So, as members will be aware, this review's been around for a while, and COVID kind of happened in the middle of it. So, in terms of the way things were taken forward, some of the recommendations were implemented fairly well, and others, it was a little bit more challenging because things had changed. So, what's being proposed is that in future, any further developments because they're not necessarily going to be implementing the recommendations exactly as they were, because it's now kind of obsolete, it's being proposed that we have any developments in terms of GP practices just included within our normal updates that we get from people like Dr. Prasad or the ICB.
Cool. And if we have any questions, obviously Nikki can take them back to the relevant people. One note, not a question, is obviously lots moved on since this report was done, but ultimately the issues of GP pressures certainly is here and something that's important. And whenever Dr. Prasad is here, we always have quite a long session because there's lots of issues. But so it's something, it is an issue that we're still looking at. Does anybody have any questions that they'd like Nikki to take back? Okay, Philip.
Just a quick point to make. I mean, that all sounds perfectly reasonable, but I think I'd be sorry to see the thrust of recommendations being lost in new reporting. So if that's how we're going to do it, can we perhaps reference recommendations that, you know, the origins of where a particular action has come from? Because we do spend a lot of time and effort on these reports, and it'd be a shame to lose the essence of those things. Yeah.
Sorry, June.
It's very important.
Sorry, June. Sorry. I'm going to go to Adam after Philip, then I can very welcome to come to you. If we had a clock, you've had a lot of clocks so far, which is great because you do prepare and you ask some very good questions. But Adam hasn't spoken yet, so after Philip I want to go to Adam, then I'll come back to you, okay? Philip, is that everything from yourself? Yeah. Fantastic. Adam.
It does work. I feel really bad now. No, my question, and I don't know whether it's something we can get a response from the GPs on, but is something that residents get quite frustrated with, is Section 106 agreements in planning applications, where particularly with large residential developments, a sizable amount of money will often be earmarked for local health services, and often developers will pitch to residents that that is for a new GP surgery, but it is ultimately for the NHS somewhere to decide what to do with it, and invariably it is invested in local services. Is whether or not over a period of time we can look back and say this is the amount of money that was contributed via Section 106. How has that been spent across the borough? And are there sort of variations by geography, you know, and can all of the monies be accounted for tangibly? And is it the case that there is money that just is waiting to be spent because it's stuck somewhere?
Very good question. And what's outstanding, that's a sort of part of it as well. So, yeah, Nikki, if you could take that back to whoever can answer that, because I think that is a very good question. Good. You know who, Nikki, unsurprisingly, Nikki knows who to ask. That's good. June.
I just want to follow up on Philip's question there, is that after we've done so much work and listened to so much information, I think we need to tag on to whatever discussion comes up around that so that we are in tune in what's going on, but not forgetting all the hard work that's done. And it would be important that if we have that all linked together. That's all I wanted to say.
Good stuff. My feeling, it's only a feeling, so it's not worth doing anything else with it apart from, I know, don't look at me like that. I often get feelings when I'm here. But is that GP pressures, how it works. I mean, obviously we're coming towards the end of a big review at the moment, and then those of us who still remain in this committee next year think about other big reviews, but it's definitely something I think that, you know, needs to be looked at again in the bigger instance anyway. So, Adam.
I'm on a roll now. I thought of another one. So another big issue that's discussed at the moment a lot around GPs is in-person appointment versus telephone. It would just be interesting to see across the borough how many practices are offering an in-person appointment for those who want it, or offering it in the first instance, or has it, very much like my surgery, gone to you get a telephone appointment regardless. It's just making sure that, I guess, the community feels that they are getting access to their GP in the way that they feel is warranted. I had an example where I waited 3 weeks for a telephone appointment, even though I'd asked for an in-person. I was told I couldn't have one. And then after 3 weeks, the person on the other end of the phone said, well, we need to see you. So then you have to wait another 2 weeks to get an in-person. And you kind of feel like that's just so inefficient. But listening to sort of radio stations and phone-ins, you kind of, that feels like that's become more the norm now, rather than the exception.
Rita, sorry to I know you haven't got your hand up, but before the meeting you did discuss something actually sort of relevant to what
Relevant, yes.
Adam...
I think a few months ago, Chair, we did ask for an update on this new system that was meant to be coming out for appointments. So basically, could we have an update? Has it been implemented? Is it working? In line with Councillor Bennett's question, what's the ratio of face-to-face? Because that was supposed to alleviate the problem, wasn't it, for appointments? They were saying that we would be able to get a quicker appointment system. I wouldn't have to be on at 8 o'clock in the morning, and I wouldn't have to wait 2 weeks. But nothing's changed.
But what's also dangerous, and this is a danger actually, Nikki, of not having an officer here to talk to us about this. We're going to go off on massive UEs on this. But with Councillor Bennett's example, that service to me doesn't sound good. Where do you complain to? Where's the accountability? Those are sort of interesting questions to look into as well. Sorry, Tony's got his hand up. Then June, I'll come to you.
Well, oddly enough, on the subject of my GP, there's a queue of people complaining about not being able to get through with the voice thing, and they've taken them to a small room to explain to them about the appointment system, and it's a lot of elderly people. I noticed at my practice, and there was people just, instead of ringing up, just walking into the doctor's surgery and asking for an appointment, going that way, and they were getting one in the future. But it was there was a lot of elderly people that were. I chatted to a woman who was queuing up there, and she said, "I just can't cope with it. It's just driving me. It's affecting my. It's making me feel worse." And yeah.
Yeah, the system that's set up, I use it a lot because of some health issues I have. And if you have to be at the phone like 5 minutes to 8 in the morning, and when you call up, they then send you a text for you to go online, and you have to give a description of what your illness is or what it is you want to say, or why you want to see the doctor, which I think that is not good enough because, like Tony said, if you've got an elderly person, have no IT access, no nothing, that's not very helpful at all. So they do need to come back and tell us how it's working, because they did reassure us that this new system will help to cut down on face-to-face appointment, but also will help to triage people in the right way and give that service that's required. I'm surprised to hear about you still going to that long wait. It's not acceptable, really. And yeah, we need that.
Rita, you got your hand up.
That was just following on from what Councillor Bell said about we were in a formal meeting about complaints. So maybe that's something that we could follow up on as well. How many complaints do they receive about appointments or anything in general? And can we have some feedback on it? You know, how easy is it to complain, and how quickly is it resolved? Because clearly 5 weeks later, I'm still waiting for an appointment.
So one of the things that we've done, and I'm jumping to the work plan very, very, very briefly, and we'll get to it properly later, but we kept our February meeting pretty free to do a single issue meeting, to concentrate on a single issue. And at our next meeting in November, we're going to discuss what we want to do with that single issue. My feeling is maybe the single issue meeting could be dedicated to GPs in some way. We could form it in another way. But I mean, if the committee's okay, could one of the options be that we look at in our next meeting for the single review be based around the conversations we've had today? So does that sound like a good idea? Yeah. Not everyone's nodding. Okay. Brilliant. Okay. All right. Well, if we agree in November, we've got 3 months before the meeting, so hopefully, yes. I won't do any jokes. I got told off for jokes. Well, one of our main fans who watches us told me off for telling too many jokes at the last meeting, even though it's 3.5 hours, which I think a joke was needed. But anyway, but yes, I think that's the feeling that has been discussed today about the GP meeting. It's something that we discuss with our constituents, so I think it's definitely possibly a very good item to look at for a single review meeting, but we'll discuss and confirm that in November. So thank you. All right, excellent. So we're all happy to move on to the next agenda item? Oh, Adam, yeah, come on.
Just a couple more quick fire points. Just on stats, it would be really interesting to see if the data exists, how many GP appointments are no-shows, and how many patients get to see their actual registered doctor because I think a lot of residents' criticisms as well is in the past you would have had a family doctor, you would have seen the same person, they got to know the history, and actually now it feels like we can get you an appointment in 3 weeks, but you're going to have to see somebody else. And it'd just be interesting if there's any data on that for the borough.
Great. Thank you. Thank you very much. Okay, let's move on to agenda item 7. So agenda item 7 is our main big review that we've been doing for the year, which is the CAMS referral pathway and children's mental health services. In August, we had a sort of informal meeting where we discussed the review, where we're at and what our recommendations should be. And then over email, we've refined those, including some other themes that can go out for the report. So this is to sort of note that these are what our main recommendations are going to be. And if the committee is happy with those, then what me and Nikki will do is we're going to go out to some of our witnesses to sort of test them and get their views on them, and then to create the report and bring it to us. So, are we all happy? Does this reflect accurately what we think, Philip?
I think it does. I would just make the observation that this is perhaps it's certainly the second, possibly the third time that a committee of this council has looked at this issue. Nailing progress when it comes to CAMS is like nailing jelly, to be honest with you. It is extremely difficult, and I actually think with each recommendations, less is more, and something that's tangible that we can very clearly hold partners' feet to the fire in the nicest possible way in terms of performance over time is really what we need. I'm interested to hear what our stakeholders make of these recommendations, but I'm hoping that this will fit the bill, and for once we can really get a sense of where we're moving on this. So I'll leave it at that. Thank you.
Thank you. Yes, because obviously once we've done the report, then a year after it's been approved by Cabinet, people have to come back and report to us about what they have and haven't done and why. And making them tangible makes it harder to sort of say, to lose it in the smoke. Come on, Philip.
If I may just come back, I mean, I think we've heard from partners, but some of what we've heard just doesn't resonate, frankly, with what our experience is and what we're hearing from people, to be honest. So I think that would be beneficial. Thank you.
So are we happy to move on? Brilliant. Fantastic. Okay, so we're on to the Cabinet Forward Plan. Does anybody have anything they want to mention about the Cabinet Forward Plan? Oh, sorry, Philip.
Thank you. I will share that we did discuss this earlier, and at your request I'm raising it at this point of the meeting rather than any other time.
Work programme? Is it the issue to do with your report?
Actually, it is.
Yes.
Fine. I'll park it for this item.
That's
fine.
That's a teaser for everyone else when we get to the next item. Cool. So are we okay to move on to the next item? Yep. Okay, fantastic. Okay, next on the work programme, Philip.
Okay. All I wanted to say on this was, on the subject of major reviews, and when we see them, last April of 22, I presented on behalf of the formerly constituted POC, I think it was, the major review on assistive living technology. I'd really like to understand where we are on that. I'm pretty sure it comes within our remit as a select committee. I'm not aware of when we're expecting to hear more about progress, and I would ask that we perhaps Nikki would have a look at that for us. Please.
Yeah, because I mean, to my knowledge, it's not on our agenda.
No.
Or am I wrong about that?
Chairman, it's not on our agenda, but I did have a conversation with Gary Collier about this fairly recently. I don't have the information to hand, but yeah, I'll need to report back to the committee. I did actually speak to him fairly recently about this to get an update on it.
I think it is something that we'd be interested in hearing about, because it did sound like a very good and interesting, useful report. So thank you, Philip, for drawing it to our attention. Does anybody else have any comments about the work plan? No. We had a pretty big discussion about it at our last meeting, actually, so I think it looks good. Okay. Is that it? Excellent. Okay, well, thank you very much, everyone, and I hope you have a good rest of the week.